Dr. Mary is the founder of Modern Med, a preventative medical practice that serves people in several states, and her primary focus is on, and this is what's important to all of us, closing that gap between health span and lifespan. And today she is here to help us to know how we can move better, feel better, and live better longer. Dr. Mary.
We're going to talk about the science of muscle metabolism and women's longevity, but first I would love to do a visualization for you guys. So if you want to close your eyes or keep them open, but I want to bring back what kind of Edie was doing before, where do we want to be from a physical body standpoint in your 80s, 90s, into 100? Have you ever thought of that? What do you want your body to be able to do? Do you want to be able to go for a hike? Do you want to lift your grandchildren? Do you want to be able to climb a mountain? Are you okay being in a wheelchair? Where are we at here? There's like a big spectrum, right? And so just to get really clear about where you want to end is a great place for us to start. What we usually don't plan for is how we're going to get there. Because if we stay exactly where we're at right now, we are going to decline versus be able to be where we want to be in our 80s, 90s, into our hundreds. And I was doing that exercise on my own chair when other people were speaking and I was supposed to be paying attention. I'm sorry, no, I'm kidding. But what it came to my mind is that I want to be Edie when I'm like 85 years old because she's skiing in Japan. Like, how amazing is that? I love it. Woo! All right, so I'm going to start with a case study. This is two different archetypes of women that can come into my practice. They're fictitious, but I want to get a couple points across with this. So woman A on the left-hand side and woman B on the right-hand side have a lot of things in common. They're both 47. They both have an A1C of 5.2%, meaning they're metabolically healthy. They're not pre-diabetic or diabetic. They eat a whole foods diet. They both have a body fat percentage of 34%. Their lipids are optimal, so normal LDL-C, normal ApoB, triglycerides are all normal. And what we see is different is that woman A is 93 pounds and 5'2". Woman B is 140 pounds and 5'2". Based on this information, assuming all else is normal, who thinks woman A is healthier with a raise of hands? 0. Who thinks woman B is healthier with a raise of hands? Okay. Who thinks you don't have anywhere near enough information to answer this question? Raise your hand. Awesome. Cool. We're on the same page, so I'm going to give you a little bit more information. These are just pictures from the web. I don't know any of these women, but just to give you a general idea of the archetype that I'm talking about here. Woman A is very thin. Her BMI, if you calculate it, is 17, which puts her into the underweight category. Whereas woman B, her BMI comes out to 25.6. Normal BMI ends at 25.9, so she's slightly overweight. However, woman B weight trains 3 days a week for 60 minutes. She does cardio 3 to 4 days a week for 45 to 60 minutes. And she can do 3 to 5 unassisted pull-ups, lifting her body weight over a bar. Now, woman A is underweight. She does regular kettlebell exercises, she says, but it is once a week for 30 minutes. And she can't do any unassisted pull-ups. Assuming everything else in these women's lives is exactly the same, who thinks woman A is healthier knowing this? Who thinks woman B is healthier knowing this? I would completely agree with you, and of course this is fictitious, but I really want to prove one point or a couple points today is why being underweight or under-muscled is just as big of a problem as being overweight or over-fat. And when we see women walking around, we often associate a thinner woman with healthy and a thicker woman with not. And we really have to rethink that paradigm because it's just not true when you become objective about what health actually is. So I think one of the biggest pillars in women's health that's completely overlooked is exercise. And there's a really good reason for this, right? So if you've been to a primary care doctor in the last few years, you get a few minutes with that doctor. In fact, it's about 15.7 minutes is the median doctor length visit right now. In that 15 minutes, about 6 topics are covered on average, with 5 minutes, only 5 minutes on the biggest, most important topic that you want to discuss with your doctor. And so how on earth are you supposed to talk about exercise to the depth and the degree that we really need to have it in primary care? So why does exercise matter so much, and why am I so passionate about it, which is one of my favorite things to talk about, is because we know how effective it is at increasing longevity, but also how well we live while we're here. Now, for women, what may be surprising is that women at all stages of life exercise less than men. Did anyone know that? Show of hands. Couple? Yeah. This was a surprising one for me, but if we look especially at the age group of 65 and older, only 10.8% of women meet the recommended guidelines for aerobic and strength training. Only 11% of women. It's a really small number. And we can see that for each age group, it's less than the men. And so we need to start talking about this more for all humans, but especially for women. Why does muscle matter? So muscle, yeah, it makes you sexy, it's got some benefits, but it has a ton of health benefits. And so for mortality risk, if you're in the upper 50th percentile, meaning that you have more muscle than 50% of your age-matched peers, so 50% more muscle than all the women who are, for me, 36 years old, that means that I have between a 20 and a 26% reduced risk of all-cause death. That's huge. We don't have medications that can give you those numbers. And so what we know is that if you have more muscle on your body, it becomes protective virtually for every cause of death. Now, why? So muscle has a bunch of different actions in the body. I'm just going to go over just a few. But if you have more muscle on your body, it actually increases your basal metabolic rate. This is a fancy word for your metabolism, how many calories you burn if you were just to sit on a chair all day long. It also is going to increase your body's ability to burn fat as fuel. So it increases fat oxidation, which a lot of us could use. It increases insulin sensitivity. We had a few people talk about this. Dr. Molly talked about it. A few people did, where insulin sensitivity is like the key that opens up your cells and allows sugars to go into the cells to be burned as fuel. You need to be insulin sensitive for that to actually happen. And so having more muscle actually makes you more insulin sensitive. One of my favorite ones is that muscle allows for insulin-independent glucose uptake into cells. So what this means is if I'm going for a walk, my calf muscles are contracting, right? It's an actual pump force that starts to happen. And typically we need insulin to go in, unlock the cell, allow the sugar to enter the cell to be burned as fuel. But when you have this pump action of the muscle going, it allows the sugar into the cell without the use of insulin. So it's almost like a little hack that we have. Furthermore, your muscle is a metabolic organ. It's one of our largest endocrine organs, and it allows us to produce things called myokines, which can be anti-inflammatory to our body, but also cardioprotective for the heart. And then we have osteoporosis, which we touched on a little bit in the other presentations, and I want to dive deeper into, but we don't talk a ton about osteoporosis. Most of osteoporosis, there was a stat today that said 80% is in women. And it's a really, really important one, and it doesn't get enough spotlight because I want to tell you why it is so important, but there's a direct link to your muscle here. And so older women who have reductions in muscle, so muscle loss, have a 2.6 times increased risk to develop osteoporosis. It's almost threefold risk, and that's really significant. I'm going to tie it back to the 2 case studies we had in a little bit. The other risk factors for osteoporosis are just being underweight. So woman A was underweight, and she has more than double the risk of getting osteoporosis compared to woman B that we discussed. Other risk factors are smoking, drinking too much alcohol, poor diet, lacking in calcium, vitamin D, medications, things like glucocorticoids like prednisone, sedentary lifestyle, as well as family history. Now, why do we care if we get osteoporosis? The stats behind osteoporosis are staggering, and I want to show them to you not to scare you, but so that we can take action and make changes so that you don't get there. So within 3 months of a hip fracture, your risk of all-cause death increases 5.75 times. Almost a 6-fold increase within the first 3 months of a hip fracture of dying. If we look at it a different way, the age at which you get a hip fracture, hopefully you don't, but if you do, really tells us about your risk as well. So if you're a woman and you fracture a hip at the age of 70, 5% of those women who fracture a hip at the age of 70 will be dead within 2 years. 5% doesn't sound that much, but if I said 1 in 20 women will be dead within 2 years, that number doesn't sound good anymore. At the age of 80, it's about 11% of women, if they're 80 years old and they fracture a hip, will be dead within 2 years. That's 1 in 10 of those women. And at the age of 90, 26% of women at the age of 90, if they fracture a hip, will be dead within 2 years. That's 1 in 4 women who fracture a hip at the age of 90. Who thinks muscle's important? Yeah. I want to go move into a little bit more of the cardiorespiratory fitness data. So this is heart and lung fitness. This is me doing it on one of my best friends because of HIPAA. You can't really post patient pictures here. But this is something that I do with all of my private concierge clients. So everybody's getting on a treadmill and we are testing your heart and lungs. When you go to the primary care doctor, they listen, right? They put the stethoscope, they listen to your heart, they listen to your lungs, they have you take a few deep breaths. But what the heck does that actually tell them? It tells them that you don't have a heart murmur. It tells them that you don't have wheezing or there's not liquid, fluid in the lungs and everything sounds clear, but that's pretty much it. It's not telling them anything about the actual fitness level of your heart and your lungs. And that's really what we care about into longevity specifically. So what does the data say here? I have 2 graphs here. The one on the right is going to show all patients, men and women, and then we have just women separated out on the right. But if you go from a low level of cardiorespiratory fitness, so you're not in shape, if you go from that low level to below average, over the course of 10 years, if you started at the age of 50, you get a 50% reduction in all-cause mortality. Tell me one medication that does that. None. 0. If you go from a low level to above average, you get a 65% reduction in all-cause mortality from moving your cardiorespiratory fitness level to that low to above average. Now, if you're like, I'm going all the way. I'm going from low to elite level, you have over a 5-fold increase in risk reduction in mortality. It's incredible. There's literally no drug on the market. If there was, it would be the #1 selling medication. Okay, raise of hands if you think that your metabolism has slowed as you age. You used to be able to eat anything, now you can't eat anything, you gain weight no matter what. People are being shy, but there are slight hands going up. Okay, here we go. It's a really, really common thing that I hear in my practice, like, I just can't eat anything anymore, I gain weight no matter what. There was a study that came out in 2021 that really started to debunk this idea that your metabolism slows as you age. So the study looked at total daily energy expenditure and basal metabolic rate. So let's just call it your metabolism, right? And they looked at it over the course of the whole human lifespan. And what they found is that basal metabolic rate, your metabolism, if you're just sitting down all day long, is very tied to how much muscle mass you have on your body. And men tend to have more muscle than women. But if you correct for muscle mass, so if you say, we're going to take out that variable in this picture, men and women don't have different metabolisms. It's all based on how much muscle they actually have. What was more interesting, though, is from the ages of 20 to 60, if you correct for how much muscle is on somebody's body, your metabolism does not slow. Do we get that? Your metabolism does not slow from the ages of 20 to 60 as long as you correct for lean muscle mass. After the age of 60, the authors did see a very small decline in metabolism, but I'm talking 0.7% per year. That's very, very, very small. That's not going to make up for what we are feeling, where it's like, I can't eat anything anymore, right? And so what is going on here? Well, your muscle mass is very likely declining as you age. And so we have less muscle, our metabolism will slow because of the muscle. And remember back to that first graph that I showed, as we age, we move less. We exercise less, with only 10% of women meeting the recommended daily requirements for exercise for both aerobic and strength training at the age of 65 or older. What does slow is your hormones. So once we hit menopause, hormones are going to be drastically different. You're going to see reductions in estrogen, progesterone, and estrogen not only helps to prevent hot flashes and mood swings and night sweats, but estrogen also helps to maintain your muscle and keep you strong. It also helps to reduce visceral adipose tissue, so fat that's around the midsection that's tied to an increased risk for cardiovascular disease. Estrogen helps with fat redistribution. It does not help you lose fat, but it helps you to redistribute it in a way that's less cardio risk factor wise. And I just made up that sentence, but there we go. And estrogen really protects our bones. And I hope if you leave with one thing today, you realize that you don't want to break a hip, right? Testosterone declines as we age naturally as well, and testosterone is very, very protective for our muscle and to keep us really strong. Testosterone is also very protective for our bones, and we want to think about that as we are going through the perimenopausal and menopausal years. And so hormone replacement therapy does have a place in my mind in longevity because of these effects on our bodies. So hormone replacement therapy may help with redistribution of fat, meaning reducing visceral fat, making sure most of our fat is around our hips, butt, and thighs where it doesn't really bother us. However, hormone replacement therapy does not lead to weight loss. I have women all the time that come in and they're in the perimenopausal, menopausal transition, and they say, I want to go on hormones, I need to lose weight. And I say, we can get you on hormones, and there's reasons to do that, but you're not going to lose weight from them. It can help with the redistribution, though. Back to our case story, woman A versus woman B. If we look at this again, I think that we should probably have a better understanding right now of why woman B is likely healthier, how much stronger she is than woman A, how much more muscle she has on her body, how much more cardiometabolic exercise she's getting on a weekly basis to really improve her heart and lung fitness too. So fitness beyond the scale. How I view these women, because one of the things I want you to leave is actionables, right? Like, what should you do with this information? But I can't tell you all to do the same thing because you're not all the same person. And so I want you to look at my methodology and how I view these women and how I would help them if they were my patients. So woman A, I consider her underweight and undermuscled. She doesn't have enough muscle mass on her body for health. So our number one goal is going to be for her to increase her weight primarily by putting more lean muscle mass on her body, which is going to reduce her risk for metabolic diseases, but also osteoporosis being a huge one. So resistance training 2 to 3 days a week for 60 minutes each time is going to be the end goal. If I tell somebody who's doing 30 minutes a week to do that right now, they're going to say, okay, bye, see ya, and I'll never see them again. And so we want to start with whatever is actionable right now for you. And if that's going to be 5 minutes of doing biceps curls with the 5-pound dumbbells that you have in your home, then wonderful. Start there. But the biggest mistake that I see women specifically make is they just are exercising, which is great. Exercising is better than not exercising. But if you want to actually get to a goal, you need to have an actionable plan to get there. So if you are an all-star NBA player and you're trying to get better at your layups, you wouldn't start hitting a bunch of baseballs, right? You wouldn't start skiing. Like, you would fucking do layups. Oh my God, am I allowed to swear? I haven't been. You would do layups, and you would do a lot of layups, and you would keep doing layups until you reached your goal, and then you'd be like, okay, free throws next, let's go. And then you do a bunch of free throws, right? Like you do the same thing, but with exercise, I hear women all the time, they're like, I go to Pilates on Monday, and then I do HIIT on Thursday, and then I run on Fridays, and then I go for a walk. I don't know, I have a Valley Girl accent, but you get the picture where you're just like jumping around and you're doing all this stuff, and all of it's great, but how are you going to get to a goal if you keep jumping around? So with exercise, it should be really a prescription. Just when I write a prescription for, let's say, Lexapro, it's 10 milligrams, take it in the morning, take it every day, with food, without food. Has to be that specific. So resistance training, that's not that specific. Which exercises are you going to do? What intensity, what weight, how many reps, how many sets, and how many days a week are you going to do it? And you want to plan it just like you would anything else, and start slow, low, gradually increase from there, but know where you're trying to get to as well. I would eventually add aerobic training into her routine too. I do the VO2 max test to determine zone trainings based on heart rate. I love data, and so we use it a lot, because if you have data, you can track where you were, where you're going, and where you want to get to, and you know if you actually achieve that goal as well. And she definitely has to increase protein too. So proteins are going to be the building blocks for making that muscle. If she's not eating more protein, she's not going to be putting on the weight. Creatine, whey protein would be great supplements for somebody like this. Woman B, really quickly. She is slightly overweight. So her main thing is just losing a little bit of fat. And that's actually pretty simple compared to what woman A has to do. I would say it's going to probably take woman B a little bit more, or a little bit less time than woman A to hit that goal. This is about reducing calories, but keeping protein really high to spare as much of that muscle as you can with weight loss, and continuing her progressive strength and aerobic training, which she's already doing a ton of throughout the week. So it's just making sure that she has goals and she's meeting those goals. And so when I'm looking at somebody and where we start, I usually am going to put most people through a body composition test, looking at a DEXA scan, so we actually know how much muscle do you have on your body. I calculate something called ALMI, your appendicular lean mass index. It's how much muscle you have on your arms and legs. And there's places that you can go to get these done, and they're like $50, $60, really affordable and definitely worth it. Not for everybody. If you have a history of body dysmorphia, eating disorder, please talk to your doctor about it. We don't want to make anything worse. VO2 max testing is becoming more and more available. I actually have my metabolic cart in the back. If anybody wants to do a metabolic test, we can. We're not going to do full VO2 max today, but please just tap me. But you don't have to do this either, right? You can just pick up the dumbbell in your living room, start slow, go low, but have a destination that you want to get to. Things to consider: type of exercise. What do you like doing? Duration, intensity, frequency, progression, rest, and recovery. This is a quote from one of my patients, and it's just a reminder that body composition, weight, talking about being over fat or underweight or whatever it is, has triggers for everybody. To be really kind to yourself or to your patients if you're a practitioner. This is sensitive information, and it can really change the trajectory of somebody's outcome with how we communicate with them. Thank you guys so much.